So please, can I have Dr. Isha with your talk? Thanks.
The interaction of myopia with glaucoma risk remains complex, largely because of the retinal and nerve fiber layer damage that occurs in myopia alone. So, whether to treat for glaucoma relies on the suspicion level of the clinician, who must consider other risk factors for vision loss. Ultimately, it is the progression of glaucoma like findings that determines whether or not it is to be treated. So, let us look at a case scenario. This was a 24-year-old female referred for refractive surgery. So the findings, best corrected visual acuity with a refraction of -5 diopter sphere in the right and a -1 cylinder, and -5.5 spherical in the left with a -0.75 cylinder, was 6/6. CCT okay relatively for 534 and 549. This is the topography of the right eye. So the readings are K1 is 42 and K2 is 45, and the map looks okay. No local areas of steepening, thinning. This is the left eye. K1, K2 relatively on the higher side, 47 and 50, but then regular structure. So looking at her optic discs, now we can see here that the ONH is slightly nasally inserted. I'll just. So the ONH is slightly nasally inserted here, and the CDR looks suspicious. It's a CDR of about 0.6 in both the eyes. There is bilateral beta zone parapapillary atrophy without any visible defect of the RNFL. It's better to have a red-free picture in order to see defects of the RNFL. And there is no significant focal rim notching or saucerization. So this patient was referred for a glaucoma opinion. And also she had a similar looking disc in her mother who had come for a routine checkup. So the fields look okay, perfectly all right. This is the RNFL imaging of which shows certain red areas in the right eye superior and nasal quadrants, and in the nasal quadrant of the left eye. But then the RNFL symmetry is well maintained. So what are the dilemmas in this case who has come to us for a refractive surgery? This is a young myopic patient with large optic discs which are glaucomatous looking. So does this myopic patient have glaucoma? And her OCT imaging shows bilateral signs of structural anomaly of the optic nerve head, or the red disease which we saw. So should we proceed for a refractive surgery? A little bit of background. So glaucoma is the leading cause of irreversible blindness worldwide, with 67 million affected, 10% of whom are blind. Incidence of glaucoma is increased in patients with more than 6 diopters of myopia. As we know, myopia is increasing rapidly worldwide, with the myopic population expected to double in around 2050. High myopia is defined as the axial length more than 26.5, spherical equivalent more than 6 diopters. We already know that. So use of refractive laser correction for myopia further complicates this picture. Why? Because there is a transient rise in IOP during LASIK surgery, which may put an at-risk patient in further damage of due to glaucoma or even retinal vein occlusion. Then IOP measurements are inaccurate after laser refractive surgeries. Why? Because of alterations in the CCT and corneal curvature. And patients with glaucoma are at a higher risk of developing steroid-induced IOP elevation because of the post-operative regimens. These are some large studies, large center studies, which have established that yes, myopia is a risk factor for glaucoma. So why are myopic eyes predisposed to glaucoma? As you can see, lamina cribrosa is the primary site of RGC injury in glaucoma because it's a connective tissue sheath, a narrow sheath through which the axons pass. So very prone to damage from compression. So shearing forces in the lamina cribrosa secondary to connective tissue changes are greater in eyes with a longer axial length than those with a shorter axial length. I've quoted the study below. So this may explain the higher susceptibility of myopic eyes to glaucomatous optic neuropathy at any IOP. Posterior deformation of the Brooks membrane is observed in myopic eyes, and that is associated with functional glaucomatous damage. And confocal imaging has shown that the height of the optic disc is relatively decreased with increase in the axial length. But sometimes imaging a distorted optic nerve head that is structurally different from that of a structurally different from that in a non-highly myopic population, which actually is used as a reference normative database in the OCT imaging software, may lead to misdiagnosis. Why? Myopic eyes can be associated with optic nerve head abnormalities that can create diagnostic challenges. Quantitative parameters on RNFL imaging are important, but false positive findings of RNFL thinning are seen in non-glaucomatous but myopic eyes. Interpretation of RNFL measurements is further complicated by changes like myopic optic disc tilt. So who do we call a disc suspect? Optic nerve head or RNFL appearance suggestive of glaucomatous damage. Highly myopic nerves can exhibit nasal insertion of the optic nerve, which we saw in this case, tilted disc, shallow cup, peripapillary findings like scleral crescent and PPA. Then we know about the posterior segment anomalies that are seen in highly myopic eyes. Let us look at some confusing situations. Now here, in both the eyes, there is a nasally inserted optic nerve with a scleral crescent and peripapillary atrophy. Not much cupping, but the cups look shallow. Then these are two different patients, image of the right eye. So on the left picture, the disc is nasally inserted with healthy NRR, relatively healthy NRR. On the right, it's a nasally inserted disc with a larger cup. Now, this appearance is a diagnostic quandary. But when compared, cupping is obviously more in the right picture than the left picture. Then here we can see a myopic scleral crescent, 360 degrees, hardly any discernible cup to disc ratio. Nerve fiber layer imaging in myopia, there have been studies which show that there is a average decrease in RNFL with increasing refractive error and increasing axial length. Another case, just an example, then this case was labeled as glaucoma, referred for a second opinion, and she had a history of using prostaglandin analogs. The red-free picture shows a perfectly normal-looking nerve in the right eye and nasally inserted nerve in the left eye with a temporal crescent. Global thickness shows superotemporal RNFL thinning, but it is doubtful whether the OCT scan actually considers the border of the PPA or the actual disc margin as the temporal limit of the scan. The red-free image shows definite cupping here, so this is suspicious, and the RNFL shows a red disease. Another paper. Now here, they are developing a myopic normative database. So this has application in improving the specificity without compromising the sensitivity for detection of RNFL abnormalities in eyes with high myopia. So such a myopic database would be very useful in such patients. Most important, we need serial disc photos to monitor glaucoma. These are better than RNFL imaging because there is less noise and it is not impacted by peripapillary atrophy, scleral crescent, disc tilt and all these things. And it can better monitor for change like increased cupping, localized rim notching, increased PPA and vascular changes. Just a couple of slides on the visual fields in glaucoma. High myopia can cause visual field changes due to nerve or retinal abnormalities. Visual field defects that favor myopia are temporal defects respecting the midline and an enlarged blind spot due to PPA or scleral crescent. Those that favor glaucoma are nasal step, arcuate scotoma and paracentral scotoma. So these three are different examples of myopic eyes without glaucoma with visual field abnormalities. So my take-home points are that our patient, the case that we discussed, was a disc suspect with a normal CCT, pressures and visual fields. Red disease shown in OCT RNFL is explained by lack of a normative myopic database. Although myopia with suspicious looking optic discs is a risk factor for the development of glaucoma, it does not preclude refractive surgery. All such cases need a thorough glaucoma workup, and serial disc photographs would be much more useful compared to RNFL imaging. So, thank you.
Thank you, Dr. Isha. So I just want a quick question. So would you want all such disc suspects or patients who have a disc asymmetry or large cups, should they all undergo glaucoma workup, or we can avoid in some cases? What case would you advise that we should send a patient for a glaucoma workup? What should be the red flags?
Okay, so sir, for like this in this patient, there was a
This
strong
patient.
family history.
Yeah.
So that is there. Then the red disease seen on OCT on RNFL imaging. So yes, glaucoma workup is a mandatory thing for
Mandatory.
everyone undergoing refractive surgery as a part of the preoperative workup.
Okay.
I would.
Thank you.
So, Dr. Isha, another question. So, in your regular practice, do you prefer all the patients should undergo, like as you said, it's a mandatory practice. Do
Yes.
you practice that in your regular practice?
I try to, ma'am.
Okay.